All right, I think we'll go ahead and get started with our meeting today. Thank you everyone for joining us for this Recruitment and Retention Committee update, as well as an overview of some of the diversity, equity, and inclusion efforts across SWOG. Sometimes I will refer to diversity, equity, and inclusion as DEI, so just want to let you know that shorthand. I am Allison Caban-Holt, and I am the Recruitment and Retention Committee Chair. And we have a great set of presentations for you. Next slide. Our Recruitment and Retention Committee's mission is to advise leadership on effective methods for recruiting and retaining minority patients to SWOG trials, as well as to better recruit and retain minority SWOG members and leaders. And these ideas reflect SWOG's guiding principles of having diversity in membership and leadership, as well as in participants in clinical trials. We have had the pleasure of having some fantastic presentations over the past several months, including some of our in-house experts, such as Ellen Richmond, discussing quality improvement in the quality improvement program that is titled AQUIP. Study teams can feel free to reach out to the Recruitment and Retention Committee if they have requests for guidance and advice on recruitment and retention into SWOG trials. In addition, in time, we are expecting that the Recruitment and Retention Committee and Recruitment and Retention Review will be part of protocol review, so that all trials being developed will have the opportunity to address recruitment and retention at an early stage with the RRC, Recruitment and Retention Committee, early in the clinical trial process. Next slide. The Recruitment and Retention Committee also has a working group that we call DIBS, which stands for Diversity, Inclusion, and Belonging Strategic Working Group. And we think that everyone should have DIBS when it comes to wanting to be inclusive. We should all be all in. And our mission for that working group is to promote diversity and inclusion among SWOG members conducting cancer research and in those participating in research. And our vision is that leadership and membership will be inclusive and support, advocate for, and enroll a representative population of SWOG clinical trials into SWOG clinical trials. The group has been working very hard. They have a specialty in looking at diversity, equity, and inclusion, and generating ideas for how to advise leadership. This group has helped create the description for the research champions, which I will be talking more about shortly, and are currently helping with the application review of those champions. The next slide. Our education working group has a Take Action series, and I love that graphic. It looks like we should just, we should fight about action. So we have the Take Action series, and today we're going to have a next item in that series. This Take Action series was developed by Kamara Mertz Rivera and Lucy Gansauer. At our last group meeting, we had ensuring health equity in SWOG trials among African Americans, and today we will have the next in that series, which is ensuring health equity in SWOG trials among Asian Americans. Our prior series was absolutely scintillating. It was wonderful. And so we are looking forward to our presentations today. The goal of this series is not to be cookie cutter, because we believe that every population, every group has some unique aspects has unique unique aspects, and we believe that it is important for us to discuss in detail how to approach different populations with regard to research. And we really want to provide advice and guidance for what actions study site staff can take to actually not just talk about recruitment and retention of different populations, but can actually, what actions that they can take. Next slide. So we have had significant support from the Hope Foundation and Genentech for DEI efforts in collaboration with the Patient Advocates Committee. So one area, so these are some of the things that are in process and as well as things to come, is the funding of a diversity, equity, and inclusion consultant team by the name of Hope Consulting. And they're going to be implementing DEI efforts in research and leadership. They have already conducted leadership interviews with regard to DEI and an anonymous focus group that many of you may have participated in, and they're going to use that feedback to tailor inclusive leadership training that is going to begin in November. Very exciting. Next slide. There's also a DEI fellow by the name of Dr. Patricia Robinson, and she will be collecting and analyzing baseline data of representativeness of clinical trials in SWOG, with her goal being to achieve a 20% increase in enrollment of minorities and underserved individuals in selected SWOG trials. And she is also going to be responsible for helping to implement the Team Science Module 6. Next slide. We also have diversity, equity, and inclusion champions that are in the process of being selected. These champions will collaborate with research committees and study teams and provide evidence-based guidance for increasing diverse representation in SWOG trials. These experts will be providing tools, strategies, and guidance to reduce disparities in clinical trials, and they're also going to be instrumental in activating Module 6 of Team Science in research committees. And 5 champions will be selected. And my quote there from Muhammad Ali is, "Champions aren't made in gyms. Champions are made from something they have deep inside them, a desire, a dream, a vision. They have the skill and the will, but the will must be stronger than the skill." And I think in our case, the champions being selected will have both the will and the skill. And next slide. Team Science Module 6 was also initiated by the Patient Advocates Committee, and the goals are to understand the importance of diverse representative research participants to cancer research, and to understand how, what practices we can take to actually achieve diverse enrollment. So the module has been shared with the Recruitment and Retention Committee as well as the Patient Advocate Committee members. There may be some modifications made, and so thus far the feedback has been positive, and it will soon be shared with leadership, including committee chairs. And thereafter will be disseminated with study teams. So if you are an early reviewer of this module, please give your feedback. It's important for us to understand how to, if there are any changes that need to be made to that. All right, and next slide. I want to thank the Recruitment and Retention Committee and our education and DIBS working groups. You all are working so hard and are always there and willing to share your expertise. Fantastic group to work with. Thank you. All right. So I want to just introduce, now we're going to transition to our Take Action series. And this Take Action series is going to be focused on equity, health equity in Asian American populations. from reading Dr. Lee's journal article, it was pointed out very clearly that a primary cause of mortality for Asian Americans is cancer, and yet their participation in trials is low. And so thinking about why is that, and even as we've had discussions about how do you define Asian, that is not a single term, that's not a term that indicates one particular group, but is a number of different groups and cultures and languages as well, that we really need to have a better understanding, which is why I'm so excited about having this panel today. Next slide. This has been a heck of a couple of years for us, between COVID and other things, and I just wanted to focus a little bit on some recent experiences of Asian Americans. So when we had the prior Take Action series, and we talked about, and we were discussing African Americans, and one of the things that I really hope that everyone gets is the reasons why people may be hesitant to join research or may be hesitant to be part of institutions is not just what happened historically, but it is also the things that are happening currently that affect people and affect their trust. And in recent months, there has been, I don't know if it's a perception, it seems like there is more violence against Asian Americans. I was able to pull this. This was a Pew Research Center poll from April that was looking was talking to Asian American adults, and they're saying 8 in 10 say that violence against them is increasing. I mean, that's 81%, and then nearly half of those polled experience an incident tied to their racial or ethnic background since the pandemic began. One of these 5 incidents, if you look below the dark green bar on the bottom to the lighter green bars, feared someone might threaten or physically attack them. People acted as if they were uncomfortable around them, been subject to racial slurs or jokes. Someone made a remark that they should go back to their home country. Someone made a remark that they are to blame for the coronavirus outbreak. Someone expressed support for them, which is positive. I think that when we look at reasons why there may be lower uptake of participation in research and participating in various institutions and things like that, we also have to look at what people may be experiencing socially and how that can affect their perceptions of joining research, of obtaining medical care, trust. So I just kind of wanted to make sure that we have some understanding of some recent incidents that have been happening that may be eroding some trust or affecting the trust of Asian Americans in research, even though there's not that direct tie, but it is tied. Okay. All right. So hopefully that may have slightly set the stage for our presenters today. So that was the end of my presentation. So can bring up Dr. Lee's.
I think I'm going to control my own slides.
Great. And I'm going to just give a brief introduction. Richard Lee, who is our first presenter, is going to be discussing the impact of health equity on Asian Americans in clinical research. And I also want to point out that he he is a co-author, a lead author of a great journal article about this topic. Dr. Lee earned AD and AM degrees in chemistry from Harvard University and MD and PhD in molecular biology degrees from Albert Einstein College of Medicine. He completed residency training in internal medicine at Mass General and hematology oncology fellowship training at Dana-Farber Harvard Cancer Care Program, with postdoctoral research at the Whitehead Institute of MIT. He is an assistant professor of medicine at Harvard Medical School and practices medical oncology at MGH Cancer Center. At Mass General, Dr. Lee has a clinical focus in ternary, malignancies. He has research interests in new cancer therapies, biomarkers, and cancer cell metabolism. I'd like to pass the stage on to Dr. Lee.
Great, thank you so much, Dr. Kevin Holt, for this for that introduction. Are you able to see my slides, or is it the presenter view? Slides. Okay, great. So it's a great pleasure for me to join this SWOG Fall meeting. I'm beaming into you from the Ether Dome here at MGH. So I'm here in Boston, Massachusetts, and I'm happy to give this presentation. These are my disclosures. I want to have a thank you to the MGH Cancer and Diversity and Equity Council. This is recently a recently convened council because of everything that's been happening in the last 2 years. We've also had discussions with the FDA Oncology Center for Excellence and my co-authors, Dr. Madden, Dr. Kim, Dr. Posadas, and Dr. Yu, some of whom may be known to this SWOG audience. I guess I'll also say this is also, in a lot of ways, a new path for me personally. My involvement really grew out of the COVID pandemic, taking care of COVID patients, seeing the disparities in health as well as wealth in our society, in our local society, and then nationwide, and also this national reckoning on race that just illuminated the huge health and wealth disparities. It led to our cancer center taking a hard look at our own practices and creating our Diversity and Equity Council. And through that, that's when we started really thinking about various groups that may be impacted by biases, both implicit and explicit. So in a lot of ways, I'm still relatively new to the field here, and my angle here is as a clinician. That's really to describe the view of cancer care for the Asian American patient. So these are the objectives for this introductory talk. We'll talk about sort of how the cancer health disparities experienced by Asian Americans and then barriers to care. This is the US Census in 2020 figure showing that Asians are the fastest growing group, 38.6% change from 2010 to 2020. That's if you identify as Asian alone or Asian in combination with any other race or ethnicity. Among the Asian Americans, the groups include 24% are Chinese American, 21% Indian American. Next group is Filipino American at 19%, 10% Vietnamese American, 9% Korean American, 7% Japanese American, and then 15% for all the other groups. Importantly, 57% of the Asian Americans are born in another country, and there are various descriptions of between a quarter to a third of Asian Americans are considered proficient in English, limited proficient in English. So that's also important because this the Asian American definition, at least by the Office of Management and Budget, covers people from at least 20 countries with over 200 languages and dialects. And there's a lot of discussion about aggregated and disaggregated data. As you heard earlier, the definition of what is an Asian American is relatively difficult. Asian Americans come from many, many different countries, and as such, they can't really be considered a monolith at all. And yet, we aggregate data in ways that can be helpful and yet harmful. So, for example, Asian Americans in this aggregate data have a higher median income than the average American household, $85,800 versus $61,800. with lower percentage that have poverty, and more Asian Americans have a bachelor's degree at the age of 25. But if you look at the spread of the median annual household income from 2019 or poverty rates, there's quite a broad spread between the poorest of the Asian American subgroups and the richest. And so of any of these racial or ethnic groups, Asian Americans actually have the largest income spread, comparing the top 10% and the bottom 10%. And that holds true with poverty rates as well. So aggregated data has its own challenges, shall we say. So that's who the Asian Americans are. But let's then consider, what are the barriers to care for the Asian American cancer patient? So if we think about this Asian American cancer patient, and now I could have taken any kind of stock image, but I decided that I would just bring you a picture of my dad. So by doing so, we're just going to think about the numerous potential barriers for achieving healthcare equity. So this is my dad, and here we are from the summer of 2021. And so there are a number of different potential barriers to care, including screening, language, these various approaches or a slightly different approach in terms of healthcare that Asian Americans may take, what we'll call cultural stoicism, implicit bias, therapy effectiveness, and access to clinical trials. And when I talk about implicit bias, part of what I'm describing actually comes from the model minority myth. Hopefully this is not totally new to this audience, but very briefly about this myth, in two late articles in 1966 from the New York Times as well as the U.S. News and World Report, the writers portrayed Asians as being successful despite decades to centuries of discrimination, Chinese Americans as well as Japanese Americans. And they therefore posited that these Asian attributes such as work ethic, family stability, emphasis in education, and assimilation were keys to success. And therefore other groups that were not as economically successful did not have such positive attributes, with very clearly describing that other groups in the country, such as Black or African Americans, are quite different. The conclusion, therefore, was that race-based policies were unnecessary. They held up Asian Americans as a model minority, but I think that by taking on this mantle of being a model minority, this has only served to drive a wedge between Asian Americans and other minority groups. And then when we think about how that impacts the patients that we have, our own assumptions, our implicit bias of education level as well as financial standing impacts how we view the Asian American patient that sits with us in clinic. Additionally, if we equate the Asian Americans with white Americans because they're in this model minority category, that can lead to a poor understanding of the risks of various diseases, including cancers, faced by Asian Americans, as well as some misguided policies. So what are the barriers then? Let's first tackle screening. What are the barriers for screening? A colleague of mine, Professor Moon Chen at UCSD, describes the 3 U's. One is that Asian Americans have a unique cancer burden. Cancer is the leading cause of death for Asian American women and men, at least since '86 for women and 2004 for men. Now, cancer has become the leading cause of death for some Latinx populations as well. But I would say that we have this odd distinction of this being our leading cause of death as opposed to heart disease. Asian Americans face unusual cancers that primary care providers need to know about. These include those of infectious origins, such as H. pylori, the bacteria, the viruses EBV, HPV, and HBV. It's important to know that foreign-born residents of the U.S. account for 70% of chronic HBV infections, and many of them are Asian Americans. They also have unusual cancers such as lung cancer among Asian American female non-smokers. More than half of Asian American women with lung cancer have never smoked. So there are questions about how best do we manage such unusual cancer burden. There are also cancers that are rising with westernization, or what may be considered acculturation to the West, including breast cancer, colon cancer, and prostate cancer. And for someone like my father, understanding that none of his friends at home may get some of the cancers that are being described for some of his Asian American, Korean American cohort, makes it such that he doesn't really necessarily understand the need for such screening here in the US. There have been studies of Chinese American women, and they also similarly felt that their breast cancer rates are so low for them that they actually don't need to be screened. Last is the third view is unnecessary cancer burden. And why is it unnecessary? It's because there are certain steps that can be taken that can reduce the cancer burden faced by Asian Americans. If in terms of tobacco cessation, it's been described that only 1/3 of Asian Americans who smoke have been counseled to quit smoking, compared with half for other Americans. Their screening rates are also described as lower. And this is just from one study, but numerous other studies back the same sorts of statistics that describe lower rates of screening for cervical cancer, breast cancer, and colorectal cancer, among others. So what about cancer mortality? So I've described to you that cancer is the #1 killer for Asian Americans. This is a study that looks at the first comprehensive report of the contemporary mortality burden across 10 major cancer sites for the 6 largest Asian American populations. And so what you can see here is that these are the top 5 cancer killers in the non-Hispanic white population. And then you can see how these rates differ between aggregate Asians, Indian, Chinese, Filipino, Japanese, and Korean, Japanese, Korean, and Vietnamese, where you can see that liver cancer creeps into the top 5 for men among 4 of the different groups, as well as 2 of the different groups for women. Further, stomach cancer rises into the top 5 for a number of these groups. And so this is the danger of looking at Asian Americans in aggregate. It's also the danger of overlooking these cancers that have a higher rate of mortality in specific subgroups as compared with other American groups. Next, language is also the most obvious barrier for care. So here you can see that, as I mentioned before, 1/4 to 1/3 of Asian Americans have what's called LEP, or limited English proficiency. When we have trained interpreters, they're not always available, or they don't speak the dialect. Now at my hospital, and hopefully at most of your hospitals, interpreters are readily available. But we can certainly feel the frustration when we think we've got the right interpreter, but they actually don't understand the dialect or certain regional phrases or colloquialisms. For example, in the Philippines, there are 8 major regional dialects. And so therefore, it can be a challenge to even get the right interpretation for these patients. There's been a study published in the Oncologist that described that only half of trained interpreters in oncology environments have sufficient knowledge of oncology. And therefore, I think many of us who have spent time in the clinic and hear an interpretation that's much shorter than the long diatribe that the patient has just stated, makes us wonder, what are we missing? Additional time is required for interpretation. And so if you consider the busy clinician, pressed for time, a busy clinic, that this leads to shorter conversations about risks and benefits and alternatives, and that can really impact quality of life and adherence to therapy. If you consider the side for the patient, they're also sometimes feeling rushed and maybe unable to have all of their symptoms addressed. Lastly, patients may seek out solutions that are based out of expediency, and this can impact their care. I think these examples happen every day in the clinic. So for example, sometimes some patients may choose providers who only speak the same language. In that provider may not have the necessary expertise or introduce patients to a multidisciplinary approach that may be optimal to give them the best chance for the best outcome. A second example is that some patients will have a family member, often younger, someone who's perhaps grown up in the US, who may have better English proficiency, to serve as an interpreter. And that can lead to inaccuracy because sometimes out of deference to older relatives and to avoid the stress that comes along with, say, the term cancer or tumor or prognosis, that patients don't always get the information that they may need to help them make decisions. So language is an important barrier to care. There can be cultural differences as well among Asian Americans. So two that I describe here is a family-centric approach, wherein healthcare decisions are discussed with the family before decisions are made. And this requires extra time that's needed to bring in family members to discuss and implement the plan. And importantly, these attitudes can persist for generations, even after moving into a Western society. So even though you may have a patient whose children, or maybe second generation or third generation, this approach may still persist. Patients may want to protect their family from financial toxicity or the stress or burden of a poor prognosis. They may defer care, and that can lead to poor outcomes. There's also been studies that have shown that Asian Americans have less utilization of hospice services, particularly in the lowest socioeconomic status quartiles. And that just speaks to this intersection of race, ethnicity, and socioeconomic status. What about implicit bias? So I described the model minority myth in very brief terms. There's more in many other publications. But if you think about the model minority myth, then, you know, in this case, I turn from being the son to becoming the clinician as the oncologist. So what are the thoughts that I have in my head that I might have when I meet an Asian American patient? Well, I may think that this patient's risk for cancer X is similar to that of a white patient, because if I'm unaware of the differences of the unusual cancer burden faced by Asian Americans, I may make that assumption. I may make assumptions that the patient is a college graduate and can understand, and this has significant implications about thinking about medication side effects, schedules, clinical trial results, and how we describe the medications to patients. And then there's the assumption that because of what I described as the aggregate income of Asian Americans as compared with other American households, I might assume that the patient has the financial means to afford medication or transportation. So we're not just talking about having the insurance, but also costs such as participant burden in things like clinical trials or even just standard care. So I describe here that the assumptions actually do a grave disservice to what we should really be thinking about, is this disaggregated reality of individual cancer patients. There are other barriers. How effective are the therapies that we have for the Asian American cancer patient? Now, we have a drug for a condition, but how applicable are these results? So this is a study by the FDA looking at clinical trials from 2015 to 2019. And what they described was that 11% in red here of the global participants were Asian, but in the US, only 2% were Asian Americans. And this was in all therapeutic areas. Oncology trials were third in terms of the number of participants. So a key question is, can you extrapolate the outcomes to Asian Americans from Asians in Asia? And there are also a lot of potential differences among these populations, such as, you know, endemic rates of infection, vaccines, health insurance, cancer screening, and cultural differences in terms of diet and lifestyle. So it's a not well understood question about whether or not treatments for cancers in Asia should apply to just as equally well to Asian Americans. What about barriers of access to novel therapies, such as clinical trials? So that's what SWOG may be most interested in. And these are all coming from the slides that I've just shown to you. All these potential barriers exist. And I think that these are important things for us all to consider when we talk about taking care of patients with standard of care therapy, as well as for clinical trials. So hopefully I've shown you that a number of these different problems exist, and that policy change is really necessary to overcome barriers. Policies within our hospitals, policies within our cooperative groups as well. And as an oncologist, I'd really boil all this down to one issue, and that's access to care. How do patients get care? How do they understand their care? And so I'll give an example here, and this is prostate cancer in Black men. So this is a poignant example. I'll try to be fast here. As hopefully many of us understand, the prostate cancer incidence rate in Black men, this is in the green bar here, as opposed to white men in the US, is 60% higher, with a cancer-specific death rate that's 2.4 times that compared with white men. So that's the red bar here compared with the gray. Is it different biology? Well, a number of studies have looked to see if Black prostate cancer and white prostate cancer, how they may differ. There are descriptions of various differences that could help explain this difference in survival. Is it a difference in response to therapy? The answer to that really is no, based on these studies that have come out in the recent years, such as responses to things like Provenge, Sipuleucel T, immunotherapy, abiraterone, some of our standard therapies, or enzalutamide. And I'll pay close attention to this study in the bottom right, because this came from Michigan, Dr. Vaishampian, and in this study, the way they designed the study is that they had to have at least 30% Black participants, and they reached 41% participants were Black. So it can be done as long as we do the trials and define the groups that we want to study. And in these cases, they showed in each case that there's no real major difference in response to therapy. Maybe some Black Americans will actually do better. Is it access to care? And I think this is where the difference really is. If you look at prostate cancer when at diagnosis and look at in this table here, patients with comparable stages of disease, the tumor burden in the prostate is much higher in the Black patients compared with the white patients. So the way I think about that then is that this is really an example of access. And so if you look at this recent study at the VA of 20 million veterans, they looked at 60,000 prostate cancer cases, looking at 18,000 Black vets and 41,000 white vets. Primary endpoint is prostate cancer specific mortality. Black vets should have done worse if you look at all these social determinants of health: lower income, lower high school graduation rate, younger age, higher PSA at the time of diagnosis. What do we see here in this closed system where everyone seems to have the same type of access to medical care? Is that Black vets actually did better than white vets in terms of incidence of death from prostate cancer and all of these other measures. So it's an example of access. So it's an optimal opportunity to decrease disparity. This is just my way of thinking about all the therapies that we have available to the prostate cancer patient, and understanding that these treatments way over here on the right seem like some that Black patients may do just as well or even better than white patients. Really, the problem here is at screening and diagnosis, and that's access. So that's all just an example to say that we need to find solutions to access for these patients, whether it's screening, educating clinicians, having navigators, community-based approaches, maybe guidelines that differ for Asian American groups, education in other languages. So unlike our Latinx groups, where they may come from a whole host of different countries, perhaps Spanish language may be enough for many such patients. But in the Asian Americans, we need to think about translations, interpretations into many different languages. When we think about implicit bias, we have to think about disaggregated data. How do specific Asian American groups differ from each other? And then all the other things that I mentioned to you before: therapy effectiveness, access to clinical trials. Pharma, I think, is waking up to this idea that they need to do a better job. I think the cooperative groups like your own, in thinking about trying to improve the percentage of patients who are underrepresented minorities in every one of our diseases is an important goal. So I'd like to thank you for your attention. Sorry if I went a little bit over time, but if there are questions, please feel free to email me.
Thank you, Dr. Lee. That was really an excellent presentation. I also wanted to say that Dr. Lee's journal article is also part of the agenda for this meeting. So feel free to look at his article more in depth. And he has certainly brought up a lot of things to consider about access. And we're going to hold questions till the other presenters have finished. So please hold on to your questions or put them in the chat. Thank you, Dr. Lee.
Thank you.
All right. So next up is going to be Nueno. Hi, Dr. Nueno.
Hi. How are you?
Hi, you're doing well. I'm going to give Dr. Nueno just a quick introduction, and then he can begin his presentation. Dr. Nueno is a tenured professor of medicine at the University of Texas MD Anderson Cancer Center. His research is in the area of inflammatory breast cancer, triple-negative breast cancer, and the molecular mechanism of metastasis and cancer microenvironment in breast cancer. He is best known for his various preclinical development and biomarkers, developmental biomarkers, which led to novel investigator-initiated clinical trials related to breast cancer. He is the executive director of the Morgan Welch Inflammatory Breast Cancer Program and Clinic, and section chief of the Translational Breast Cancer Research at the Department of Breast Medical Oncology. At last, as a two-time cancer survivor, he is passionate about patient-centered research-driven clinical care. So next will be Dr. Nueno. Thank you so much.
Great, thank you, Allison, for the nice introduction. So Dr. Lee did such a fantastic job. So I'm not quite sure what I should be really talking, but I think that I'm going to be repeating some of the Dr. Lee's talk, and I'll give you my sense as a two-time cancer survivor, also participating in clinical trials. I mean, I don't have cancer at this moment, but I'll talk about my personal experience as an Asian American. So my talk is about disparities in cancer care in Asian populations. And I want to talk about three components, which Dr. Lee also have covered really well, but as not being in this particular area as a super expert, I think that the most important is who is Asian American, and then what is a clinical trial support and funding that's coming from NCI or other funding agencies, and then the cultural perspective that needs to be considered. So I think the big question remains to be who is Asian American, and it's something really difficult to define for certain peoples. And part of the reason really comes from how Asia is defined. So Asian and Asia. So Asia is a continent, right? And the continent of Asia is defined from east side, maybe toward like Japan, or it could even stretch toward the Middle East, South Arabia or Turkey, okay? So then the question is, people who lives on the continent of Asia could be defined as Asian, but generally the Middle East sometimes is really not, people may not say those are Asians, and everybody have different definitions. So we really have to think about what is Asian and what is the cultural background or demographic behind it, because it's a mixture of a lot of people. And we have to also remember, if you look at the world's population, Asia is the largest, continent with the most populated area. So if you look in the US adult population, roughly about 6% is considered what we call Asian Americans. And this Asian American population percentage is different, really depend on the state. And like Texas is probably on the lower side compared to other states like California or Dr. Akoba, who's will talk about, he's in Hawaii. So the location does have an impact of the impact as an Asian American when you get your patient care. And it's also, you have to remember that depending on where you live, how many Asian American physicians or healthcare provider you see is percentage or encounter is quite different. So there are 6 groups of makeup that really makes up 85% of Asian American, which are the Chinese, Indian, Filipino, Vietnam, and Korean and Japanese. But as I said, the Asian population is represented by multiple areas. So it's less than 1%, but you could see on the left side, there are many different, part of the world that people are originally coming from. So one of the challenge is cancer is a leading cause, and like in men, it's lung, liver, colorectal, women, lung, breast, and colorectal. But the biggest challenge, including Asians or Pacific Islanders, there are this kind of belief of higher income. They're supposed to be an ideal model citizen. And based on this, why is there really a difference in terms of death rates? And if you could look into like the rate ratio between death rate, like stomach, liver cancer, clearly there is a higher rate of death rates comparing to the white when you look at the right upper corner. And same thing with incidence rates. So then we have to think about the overall, the clinical research focus. So there are many different, research opportunity, but this is talking about clinical research focused on focus, okay? I'm not saying the PI is Asian American or Native Hawaiian Pacific Island, but it's only anything that's focused on the Asian population or Native Hawaiian or Pacific Islander. The NIH budget is only 0.17%. And from, I'm sorry, the number is wrong. I think from the early 2000 to the mid 2015, it went from 0.12 to 0.17%. So I mentioned about the general population, about 6%. There's a major discordance of how much investment has been made in this area. So this is not just about Asian American, but Hawaiian and Pacific Islander. There is a low prevalence of researchers, clinical researcher in this area. And then the other issue that's been noticed is that from the education perspective, only about 5% of the entire money is going into training in this particular demographics. And there has been noted that R01 award, first time and second time submission, who gets more actually is more toward the white populations. The causes are diverse and we really don't know every single detail, but clearly there's a difference. So part of the funding is decided by policies. So there is a complex history of Asian American community. Starting, so history of anti-Asian discrimination is quite long, starting from Chinese and Japanese in the late 1800s, from during the World War II. And moving toward, there was a Time article, or there was a lot of future that, well, Asian Americans are supposed to be smart. They're gonna become a doctor, engineering, and financially they're successful. And then now during the pandemic, there's this kind of, the virus is spread by Asian American, and there's some anti-Asian movement going on. So these are important things to know, that historically it's complex. And so why is this so important? Well, as Dr. Lee has mentioned, there's conscious and unconscious biases leading to poor understanding of the overall medical issue. And these biases are impacting, and it does impact the policies of how we approach this disease. And this is not just about cancer, but healthcare in general. And this is why it's important to understand the historical fact and where things are standing at this point. And lastly, I want to talk about cultural difference in Asian culture. So I pulled this out from the Asian American Mental Health Training Conference. And there is difference between of how you interpret healthcare data, how you communicate. Some are more verbalization in the Western culture comparing to Asian culture, asking questions versus not asking questions, okay? And, reading the mind or not reading the mind. And then, freedom of speech versus freedom of silence. And I'm not gonna, say that it's all Asian are like this, but there is a different way of approaching. And this actually has resulted in misunderstanding, and empowerment process of the patient is different. The other aspect, even as myself as a patient, is cancer carries a stigma in Asian culture, such as like bad blood. It's hereditary. Everything is hereditary. You have a family with a lot of cancer, maybe you shouldn't marry them. Having a cancer is a shame, and then you got cancer because you're not living a model life. And so that's, this is a big issue. And there's a phase in non-Western medicine. You have a lot of relatives and people from Asia, and they mean it, they try to help you. And it's much more easier to access for non-Western medicine practice. At the same time, the patient has tend to be stoic. You don't want to really, impact your family, and does not, so these being stoic have a negative impact. And there is a strong negative perception about hospice and palliative care. So, I'm basically, I do phase 1, and I know clinical trials. And I myself actually went through phase 1, but my family will talk about the thing I just talked about. Even myself, I have to admit that when they were doing dose escalation with IDH2 inhibitor, I felt like, well, is this really dose going to be same as my, people who's going on the study? Because, I was probably the only Asian at that time getting on the studies. So, am I going to have more toxicities? Is my son going to get discriminated because I have 2 cancer? 2 doesn't sound very good than 1, right? So, and my parents or in-laws questions these questions, not in a bad way, but so it does have an impact, and this stigma makes me crazy, actually. So what can we do? Well, I would like to, with Dr. Lee already talked about, but Asian is a very heterogeneous demographic. And I think it's important to understand the diverse Asian culture. Reduction of unconscious bias and understand the historical aspect is very important. Healthcare clearly could provide a pivotal roles. And it's kind of interesting because I'm, one of the few Asian American academic breast medical oncologists in Texas. So what's going to happen, what's happening because of my background as Japanese American. So I get more Japanese American patients coming to me. And because I even speak the language, they love to come to me, actually. And it's kind of good and bad, actually. And this is really something that, but at the same time, you wonder, you could empower a healthcare provider with the same health, demographic or cultural background. And those people could do a better job of promoting clinical research. And there are data to suggest that if you have the same background, you may be able to provide information more effectively than coming from different demographics. So many articles, when I actually want to give this talk, I look different articles, talks about, more direct approach to each different Asian community with the same demographic is one way of approaching the situations. So I thank you very much for the opportunity. So I'd be happy to take any questions.
Okay, thank you, Dr. Nueno. We're going to hold questions until after the other presenters. Everyone, please keep your questions or put them in the chat, and we will address them shortly. And I am starting to see some themes that are seem to be coming across as we have different presenters, especially about policy change, as well as stigma. Okay, so next is going to be Dr. Jared Akoba. I'll give Dr. Akoba just a quick introduction. Dr. Jared Akoba is an associate researcher at the University of Hawaii Cancer Center and provides support in both clinical and translational research with a focus on gastrointestinal cancers. His efforts have been in developing clinical trial protocols utilizing novel immunotherapeutic agents for the treatment of gastrointestinal cancers, and 2 interventions to reduce racial disparities in cancer treatment. Dr. Akoba also participates in oncology cooperative groups as a multiple PI of the Hawaii Minority NCI Community Oncology Research Program and Core. Thank you so much, Dr. Akoba. We're looking forward to your talk.
All right, thank you. You folks can see my slides okay? So I'll be presenting on behalf of the University of Hawaii Cancer Center NCOR, talking about strategies and tactics for enrolling Asians and Pacific Islanders in clinical trials. I was asked to speak on 3 topics, the investigator's role, as well as the responsibility of the leadership in increasing enrollment in clinical trials of Asians and Pacific Islanders, as well as discussing specific strategies to mitigate barriers to enrollment in these populations. So this is our population in Hawaii. As Dr. Nueno mentioned, we have a large number of Asians. We have a minority population with Hawaiians and part Hawaiians, 24%.
Dr. Akoba, you're going in and out some. I can't, I don't know if you need to be closer to your speaker or your microphone.
Is this better, or is it still?
So far.
Okay. So this is our population in Hawaii. We have a majority minority population with Hawaiians and part Hawaiians making up the largest proportion, and 20% identifying as 2 or more races. This is 2 tables representing the clinical trial enrollment in Hawaii. The top table showing raw numbers, and the bottom table showing the enrollment fraction. So the percent of patients with cancer being enrolled on clinical trials. You can see that in our population, the enrollment fraction of minorities is typically greater than the enrollment fraction. But one thing I did want to point out is that among the Asian subgroups, Chinese, Filipino, and Japanese, that there is significant heterogeneity among the groups. And as has been pointed out by Dr. Lee, this is one of the flaws in aggregating data for Asians. So in terms of the importance of the investigator's role, we ask our investigators at UH to provide minority patients the same clinical trial opportunities as whites. This has been pointed out by others and anecdotally by us as well, that when patients have access to and are offered participation in studies, that racial disparities in clinical trial participation, if not eliminated, is significant. As far as responsibility of the leadership at UH, one responsibility is to involve minority healthcare providers and to hire minority research staff. As has been pointed out by the previous 2 speakers, minority patients express a higher degree of trust with racially concordant providers. I actually have a Japanese woman who traveled to MD Anderson to see Dr. Nueno for treatment. Most of the oncology providers in Hawaii are minorities, as are the majority of UH Cancer Center research staff. But racial concordance is not enough, and we also have our staff undergo training in cultural literacy and health equity. Another responsibility of leadership is to obtain funding that is needed to enhance the approval of minorities. So we have minority NCOR funding, and we also have funding that provides resources to develop interventions to develop interventions and to sustain these interventions to increase minority accrual. And this is through a P30 supplement that I'll talk about. As far as strategies to mitigate barriers to enrollment, I'll use the example of increasing Pacific Islander enrollment to this trial. And this is a study looking at standard digital mammography versus tomosynthesis in breast cancer screening. This success we've had with TMIS has been through a collaboration between UH and Queens Medical Center. So Dr. Berenberg, who many of you know, leads the effort on the UH side. And Dr. Aaron Capps is a radiologist at Queens. But as you can see, there's a large number of people that have contributed to this effort. So in Hawaii, the vast majority of patients are enrolled on clinical trials at centers in Hawaii, which is at the top of the Polynesian Triangle. We also have a center in Guam, which is not here, but is in Micronesia, and that center has started to patients on clinical trials as well. But the patients that we treat come from all throughout the Pacific Islands. And it has been well documented that these Pacific Island populations present with significant cancer health disparities. In breast cancer alone, we have noticed that Native Hawaiian women have the highest breast cancer incidence and mortality in the state. And among Micronesian women, 40 and older, only 26% have ever had a mammogram. We opened TMIS in June 2018, and we quickly ramped up enrollment and were able to accrue 71 patients in the first 12 months. But only one of these participants was Micronesian. At that time, the primary method of recruitment was a packet mailed out with the annual screening reminder, letter. And because few Micronesians were actually undergoing screening, most of them did not receive this letter. So a natural intervention was to look at Pacific Islander enrollment on TMIS. Dr. Kevin Castle, who was at the UH Cancer Center, had established a partnership with a community health educator, Shrey, who is from Osrai, one of the federated states of Micronesia. And we leveraged this partnership to increase enrollment of Pacific Island populations to screening trials such as TMIS. This was initially through a pilot study through NCORE, and Shrey's efforts have been sustained through a P30 supplement. What this involvement looked at was involvement of UH in a number of events, outreach at local community health fairs, churches, going to public housing, community meetings, and in 21 community events, there were 426 attendees. And when we look at enrollment before versus after this outreach project, prior to the project, about 10% of patients enrolled in the study were Native Hawaiian or other Pacific Islanders. As I mentioned, only one was Micronesian. Whereas after the project or during the initiation of it, more than doubled the percent of patients enrolled who are Native Hawaiian or other Pacific Islander. Of note, this pie chart stops in February 2020 because many of the screening mammogram sites were shut down due to COVID. But as you can see, since we have started ramping up again, Hawaiian and Pacific Islander enrollment remains strong and has actually increased to 33% of patients enrolled onto the TMIS trial. So what we have learned with our TMIS experience is that investment and partnership with a community health educator enables building trust with groups that were otherwise unreachable. Shrey has been invaluable in helping to demonstrate the value of clinical trials, or explain the value of clinical trials and of even cancer screening to the specific island populations. Enrollment of these populations, though, does take increased time and resources for coordination when conducting informed consent, scheduling visits, scheduling follow-up. And that's where the support from the institution really plays a big role. And most recently, we've been working on translating the TMIS consent form to Chukis and Marshallese, another way to reach these populations, underscreened populations. And we hope to have these consent forms approved through WRB shortly. So thank you again for allowing me to present today on some of our experience here at the University of Hawaii.
Thank you, Dr. Akoba, for sharing with us. This is great. All right, and we'll hold questions till the end. Next, we have Dr. Jessica Huang. I'll give her a brief introduction. Dr. Huang is a tenured professor, Department of General Internal Medicine, Division of Internal Medicine at the University of Texas, MD Anderson Cancer Center. She is the study chair of SWOG S1204, a prospective study focused on screening for viral infections prior to anti-cancer therapy, and a national PI of SWOG 1614, a randomized clinical trial of anti-Hep B virus prophylaxis versus therapy or monitoring among solid tumor patients. So Dr. Huang is going to talk about some of her, about the trial as well, and we're going to go ahead and get some feedback and get some interaction after her presentation. So thank you, Dr. Huang.
Thank you so much, Allison. I really appreciate this opportunity to speak about a bit of experience with clinical trials, and just listening to the three preceding speakers has just brought a lot of emotion back for me about what it means to be an Asian American. And I'm so grateful for all that I've been learning in the last hour or so. I really thank the SWOG R&R committee for taking this initiative to spread some information about Asian Americans to the SWOG community. So thank you again. The question I've been asked to address is, why is it important to have an adequate sample size and accrual role in clinical trials to generate knowledge for the community we're speaking about? And I'm just going to tweak it a little bit and say, is it really the numbers, or is it the representative sample that we want to know? So if we take this diagram on the right, if we really want to get to the bullseye of who we want to learn more about, whatever community that we want to learn about who may be Asian American, I think it's important to figure out the questions and to get to the right population with high degree of accuracy and high precision. So that's what I'd like to try to focus on in this the next 10 minutes or so. So I've been asked to talk about lessons learned in recruiting Asian Americans to clinical research, what else SWOG can do to ensure representation of Asian American into clinical trial, and what research questions need to be explored to better understand the cancer health disparities among Asian Americans. And I just want to start off with a few disclosures. I am not a researcher who is well experienced in Asian American health disparities or cancer disparities themselves. I am a Korean American and a researcher, and my research focuses on cancer care that affects a lot of people, and many of whom have cultural origins in one of the many Asian countries. And my talk is really not a how-to manual or process, but rather a way of thinking strategically about generating this meaningful knowledge about a vulnerable population. So I want to start by speaking about a clinical trial that I have in the Houston community. And this is something that's sponsored by CPRIT. And I want to bring this to your attention about what it is and what I am learning from this, which speaks to a lot of what Jared spoke about, which is community engagement. So in this particular 5-year study, and we're about to start year 3, our aim is to find the best way to screen patients in a community clinic setting for the risk factors of these liver fibrosis cirrhosis, which Rich told us a little bit before about that. Liver cancer is a really big problem among this vulnerable population of Asian Americans. So in this study, we are going to approach 5,000 patients at a community clinic called the Hope Clinic. And we're going to enroll about 1,000. And we're going to ask them to do surveys, do labs, and get an imaging study of their liver. And then we're going to follow a few of them up for some diagnostic testing. So we're at about 200 patients now that are enrolled, and 6% are Asian Americans. And there is no eligibility on language in the study because the Hope Clinic provides services for patients who speak more than 30 languages, and they have clinical staff on site who speak the languages, and they serve as our translators. So 6% of Asian Americans enrolled. They're from China, Taiwan, Hong Kong, Myanmar, Philippines, Vietnam, but anybody is allowed to be a participant on this study. So what are the lessons that we are actually still in the process of learning? And I just wanted to show them. I think I can group them up in a couple of buckets for our discussion today, but one is vulnerability. And wow, we've been hearing a lot about vulnerability today. I just am so thankful for the academic people on this series who've shared their life experiences personally and professionally, and that is really showing up. And that, I think, is what it takes to show up in the Asian American population in the US to learn more about them. Working through our vulnerability, bringing up all of our risks, whatever clinical trial, what questions we want to ask, we need to show up with vulnerability to get to a changed landscape with the Asian American population. So we heard already from Jared about how diverse patient advocacy is really important, and he had his community health workers. We in our study, we have a diverse community advisory board, and we have a bidirectional engagement with them on a regular basis so that we can give them our information, they can give us their information, and then we do a lot with that. I seriously support Jared's comments about stakeholder engagement, and I think it needs to be inviting stakeholders in the community to the table that is set in the community, going to them, always being there for them, and not bringing them over to my academic institutional environment where it would be complicated, but bringing all of our resources to them. And that's what we do in this study, in this project. All of our resources are really at the Hope Clinic. We do not have any of our major activities at MD Anderson. They are all at the Hope Clinic. Another idea that I think it's worth bringing to this lessons learned table is one of trust. And I think it is important to find a community partners who are very engaged in the community of interest, and to build relationships with them so that there is a dual trusted component. For us, it was really easy. The Hope Clinic is a federally qualified health center. They've been providing care for decades to patients who are vulnerable, and they are a well-loved and trusted entity within the Asian American community and the rest of the Houston community. And so it was really wonderful to bring them to our partnership. And for this grant, we've compensated them. They hold the sub-award, which is a major way to engage and to build that trust, is to give them the ability to do the work that they want to do in the way they want to do it. So I want to move to the third lesson, and that is to apply what we have learned, especially as we've been discussing with our partners and the community. I think there needs to be a willingness to apply what we've learned about the vulnerable population and to repeatedly iterate what we've learned into meaningful changes into our research questions and processes. And that means to do it early, before the research has been even designed, and often so that we can hone in on research questions and the processes. For our personal project, we listened to what the Hope Clinic wanted and the community partners had asked about, and we went back several times and changed up our already translated documents and had to resend them through the IRB so that the sites felt comfortable with all the tools in hand, in language, so that they could go and talk to their community partners as well as the patients in their clinics to enroll them right then. In addition, similar to what Jared was saying, our research team resembles our target population. It's really important to do that and to create that space and opportunities for a diverse population on the research frontline clinical team so that the target population is very comfortable. So I want to move to a little bit of what else SWOG can do to ensure the representation of the Asian American population into clinical trials. And I think if I could just summarize the previous slide, is to allow the ability of formative evaluation and certainly of access to care, which Rich talked about earlier as his overall arching theme, and to do it early in the design process. I believe in rapid ethnography and to target the patient population as well as their families and study teams, and to use that information both qualitatively and quantitatively ascertained to inform the study changes, again, before and during the design process, and to address the things that we've all been talking about, whether it was language, literacy, or barriers to enrollment. I think it's also important to ensure that clinical trial standards are implemented that would enhance and continue to enhance participation, and wherever clinical trial components can be simplified, to do so. To share, make available all the translated study materials across the sites. And I also think that enriched recruitment by harnessing really great partnerships with experienced community partners who work in prevalent areas of areas that would be really important to engage for Asian American cancer health disparities. And thirdly, I think that if SWOG could continue to support research that really impacts Asian Americans with cancer, that would be a really good thing. And this is where I want to call out to my support and the leadership of the Symptom Control and Quality of Life Committee about how wonderful it is to have this support for our clinical trial that Allison mentioned, which focuses on Hep B to prevent reactivation from anti-cancer therapy for solid tumors. And I'm going to spend a couple of minutes on this study here. So before we talk about the study itself, I want to talk about hepatitis B and cancer. Hep B affects a lot of people in the US. Chronically, maybe not so much overall, but among those who were born in other countries, it could be up to 7%. Past hepatitis B, maybe a little bit more, 5%, but that's still not a large number, but it could be up to 30% among those who were born in other countries. Now, hepatitis B disproportionately affects some racial and ethnic groups. For chronic hepatitis B, I want to show you that overall could kind of low, less than 1%, but in Asian Americans, up to 3%, as Rich told us before. Among those with chronically infected, 70% are born outside of the US. Past infection, it's really hard to know, but in the NHANES data that's shown here, about 18% are in this other category, and a lot of them are Asian Americans. But past HBV in smaller community settings and other community-based studies, past HBV could be up to 30 to 40% of a particular study population. Now, cancer treatments can cause adverse outcomes in patients with Hep B and cancer, causing hepatitis flares, reactivation of the virus, liver failure, and even death. And this can lead also to anti-cancer therapy delays and interruptions. But there is something that's really important to offer patients with Hep B and cancer undergoing chemotherapy or any anti-cancer, systemic anti-cancer therapy, and that's oral medication for hepatitis B. It's very effective, can be safely administered on a daily basis. And recently, ASCO has recommended that all cancer patients be screened for Hep B before the initiation of systemic anti-cancer therapy. So this is a great time for this study, 1614, to go forward because ASCO is recommending it. They've already done their review of the national, the best data available nationally, and has made a decision that there is no way to do targeted screening across the landscape of patients with cancer. So they just said screen everybody. Use 3 tests, and patients with the surface antigen or the core antibody that's positive, these patients need further evaluation and maybe even anti-cancer, antiviral therapy. And it's important to realize that ASCO says that large randomized studies are needed to determine optimal management strategies in patients with solid tumor, which is exactly what we're offering in 1614. Here's our study schema. Solid tumor patients with chronic or past hepatitis B planning to receive any type of systemic anti-cancer therapy are going to be enrolled. So they have to be screened already and known to have infection. For cohort 1 on the left, patients with chronic infections are randomized to the first arm of prophylactic antiviral therapy, which is one of these 3 agents, entecavir, tenofovir, alafenamide, or tenofovir disoproxil fumarate. And prophylactic means they're started before or at the very beginning of anti-cancer therapy. Or they're randomized to arm 2, which means that they only get one of these 3 antiviral therapies if they develop hepatitis B reactivation. So we're watching these patients very closely, checking their labs about every month to make sure they don't have reactivation. And if they do have reactivation, we would start them as medication. In cohort 2, patients with past hepatitis B would be randomized to that upon indication that I just talked about, or randomized to the usual care approach, which is very reasonable in patients with solid tumor, because a lot of them may be getting this anyway, and their risk of reactivation may be very low. So this is a way to develop a very clear management strategy for patients with solid tumor, where their data is not readily available to guide future management decisions. Our primary objective for this study is to compare the effect of prophylactic antiviral therapy versus upon indication on time to adverse liver outcomes of liver failure or liver death in patients with the chronic infection. And secondly, it's to compare the effect of upon indication antiviral therapy versus the usual care approach on the same time to adverse liver outcomes for patients with a past infection. Our endpoints are really hard, and that is because we've listened to the NCI. That is what is needed right now at this time to be able to drive clinical changes in the future, and that is adverse liver outcome, a composite of liver-related death or liver failure, as I've depicted here below, clinically with ascites, liver hepatic encephalopathy or impaired hepatic synthetic function. And we are very interested in the clinical endpoints here listed of reactivation, and this is the ASCO and the AASLD guideline definitions that are aligned now, the hepatitis flare, which is an ALT that's increased, or disruption in cancer treatment, such as dosing treatment or death of any cause. So with that, I want to just pause and say, if it wasn't really for the support of SWOG, that study 1614 would never have gotten forward. And it's a great time because it's just in line with ASCO's recommendation. And now I'm going to switch gears to the third and last question that I've been asked to talk about. What research questions need to be explored to better understand cancer, health disparities among Asian Americans? And I am no expert here, but I'm just bringing a few things to the table to discuss. And a lot of this is what we've already been thinking about today, but just in different words. I think it's important to ask, which cancer do you want to focus on? And which Asian country of origin is the focus? And figuring out why that makes a difference, and going and trying to target that population and increase that enrollment by building partnership. Secondly, how does acculturation affect the screening and the treatment? We heard all about access to care. We really think it's a big problem, but how does acculturation of the patient affect it? And also, what are we doing as researchers to try to alleviate some of this? So navigating healthcare systems, and how are we addressing the language and literacy and the cultural barriers? Next, how can culturally competent design strategies be developed and tested prior to implementation? And this is where I think there could be some role for hybrid implementation studies. And so get yourself some implementation colleagues and try to figure out what is the best way to get some qualitative data up front fairly quickly and then trying to apply that knowledge into your design to go and find the right population efficiently and in the most authentic manner. And lastly, I think that something that Nueno brought up was that there are some cancer drugs that affect Asian Americans differently. And what are the clinical outcomes? So the whole field of pharmacoethnicity is, I think, a hot topic and one that needs to be further addressed. I'm sure I've forgotten a lot of other research questions, and this group knows more about that, and perhaps that'll come out in the discussion. So I just want to give some takeaway points here. Strategies to achieve a representative sample for your consideration, and that is for leaders to sponsor research that impacts Asian Americans with cancer. For research teams to design questions intentionally with specific Asian American groups in mind and a rationale for that. And I think it's really important to show up with vulnerability and authenticity to get to that place of transformation with the Asian American population, and to connect and build trusted relationships with community partners and stakeholders to reach our target population, and be willing to apply all the knowledge that comes through these interactions and to reiterate them into meaningful changes to our research questions and processes. And with that, I just want to thank you for your attention, for showing up today. I do want to acknowledge a couple of folks in SWOG. First, my co-chair, Anna Locke, who's just been a wonderful mentor for the whole process of Hep B and reactivation. Lynn Henry and Mike Fish in the symptom control and quality of life. Without their support, this study could never have gone forward. And I want to call out some specific people who have really helped me think through some strategies. Lynn Wen at MD Anderson, my friend Sue Wong at the World Hepatitis Alliance, and Christine Leda at the FDA. Thank you.
Thank you, Dr. Huang. You gave us a lot to think about. Now we're going to have some Q&A. Please put your questions in the chat, or if you want to speak up, that's fine. I guess I'll get started. Can you talk a little bit about, so when we started reaching out to you, we were talking about evidence-based strategies for the recruitment of Asian Americans. And I believe it might have been, was it Dr. Nueno was like, so what do you mean? so that just saying that there isn't as much evidence base. Can you talk a little bit about any strategies that you use, and what the success or the efficacy of any strategies that you use?
Well, I think when this topic came out, the first question was, there's a historical data and there's some experience data, but it's more descriptive than really solid data. And that was my impression. And you have to understand, I'm not an expert of this kind of disparities type of thing. I recognize as a physician or as a patient, I recognize it. So I think that was my first question, Allison, to you. Is what do you mean by this? And what's the data you want to do evidence-based? But it seems like we're really missing the basic information before we could jump in. I think we know what we want to suggest. I think all speakers have their suggestion, including myself, but I think when there's a need for more systematic approach was the first impression I had when you guys reach out to me.
Absolutely, and I think that's that is a common theme when we want to reach out to people who are perhaps not as represented in clinical trials or in medical trials, because we haven't reached out to them before, so we don't necessarily have as much of data about them. And so developing that research base is really important, and I think it goes to Dr. Huang's point of needing to do those trials that affect some of the populations that we want to reflect in our research, for sure. So Dr. Huang and Dr. Acoba, can you talk just a little bit more about community outreach and the importance of that in your research?
So I describe kind of our experience, and I think it was touched upon by other speakers as well. A big part of it is the culture, and finding someone who can kind of speak the language, but also who understands, how people approach healthcare. Screening is not a standard part of their healthcare system. Whether it be screening for cancer, screening for diabetes, and so I think that's, as far as community outreach, that's a large part of it. Starting with someone within their community who kind of understands how to best approach it.
Yeah, I just wanted to tag on to that. And I think community outreach is going to be first and foremost. It is step one. This kind of research cannot be done without going to the community and ensuring that the right stakeholders are engaged, and maybe even putting it out there. When we did our work with the liver prevention trial, the first step, even before putting anything on paper, was going to the Hope Clinic, sitting with them where they were and saying, we can't do this without you. We need your help, and we're going to need it all along the way. And this is a partnership, and we're going to show you by doing lots of these things. And the first thing is listening. And I think the second thing I'd like to say on community outreach is letting it go. These are the community experts. I, as a researcher, can do lots of other things. I can, be the kind of supervising individual on paperwork, but I definitely don't know the community partners, nor do I need to. That's why building trust and relationships goes a very long way, being very selective and having engagement from the beginning. I think that's, Allison, I think that's where it is like knowing what one's able to do and the strengths, and then like getting other people to the table and then letting them do their job.
Talk to me a little bit about the importance of the investigator's role in effective outreach and engagement of diverse populations. I'll go a little bit further. So can you do the outreach that is needed if the investigator or if the PIs are not, or don't recognize its importance?
Maybe I'll just say that research goes nowhere if the PI doesn't recognize the importance, right? So I highlighted the one, I briefly just highlighted in the prostate cancer world, the one study that came out of Michigan that described that this study of enzalutamide compared with bicalutamide, they specifically said we have to have 30% Black patients in here because we have to understand this population because it's usually Black patients, or maybe 5% or something of a lot of those sorts of studies. They got 41%. That's, when you have an investigator that's invested in this and a group that's invested in this, it can be done. That's all that's just a great example of that. So you absolutely need to have engagement from the very, very top. I liked Dr. Nueno's description also that, the other key things for us to really push for really are, is our national funding, NIH funding for, research that impacts Asian Americans and Pacific Islanders. There's one part that we haven't really sort of talked about is, do we disaggregate Pacific Islanders from Asian Americans? And there are some who do think in that way, and I think that's a very different type of topic. But for so long, we really have not had the adequate funding to study the problems, such as lung cancer in non-smoking Asian women, such as the higher prevalence of things like chronic HBV in Asian Americans. It's a host of different problems that I think we've all sort of described today. So how do we push for that? How do we push for money and then have investigators who are rewarded with grants and also are invested in this population to be able to push for studying the appropriate population for each one of their studies? I could talk all day.
That's great. Can you talk a little bit about culturally sensitive strategies? And I know I'm throwing out, it's pretty big because we have already had some discussion about culture, that Asian Americans, Pacific Islanders are not one culture. Can you talk with me through some of any insights that you have from your research in terms of culturally sensitive strategies that might help us better understand approaches to recruitment into cancer trials? You've already mentioned some.
So I'm not quite sure this is a good example or not, but I could tell you about my clinical practice. Okay, so I think there's a tendency that Asian is one, group, right? So if you have a Chinese, Korean, and Japanese American, okay, they're all different. And it's not that Japanese American will do well with a Korean American or Chinese American. And I think you have to show your curiosity to learn, actually, because if you kind of put it, they all have different way of thinking, and it's different. I mean, if you go to Asia, they all recognize that they have a different background, and similar thing is happening amongst Americans. There are certain things that you could approach with us one way of approaching them, but I think, and it's not that you have to learn everything, because you can't, right? But you have to have this willingness you want to learn, actually. So they, obviously when I see my breast cancer patient, and these patients will look up where I'm from and what's my demographics, and then they said, oh, I still want an Asian doctor, and then they come to me, and then well, but I, and then they talk about their, background here and there, and they open it up, and then and I said, well, this is interesting. I would really like to learn, your way of thinking, actually, because I don't, Asian is a big word, actually, to me, actually, and so you have to so you have to really go into one more depths, is the personal feeling I feel doing my clinical practice, because I noticed my colleagues will say Asian. And it's like, okay, it's not that simple, actually. I have to explain to my colleagues sometimes. I don't know if I'm answering some of your questions.
Yes, yeah, that's incredibly helpful and important, because I know that certainly in my work with looking at health equity and health disparities, some of the disparities that, or some of the barriers that exist, say for African Americans, also exist for Asian Americans, but I wouldn't necessarily know, they may be different kinds of barriers. So for example, a barrier that I think was mentioned is having your care provider be of the same background, perhaps, as the patient, and we know that certainly in African American community, we're not well represented amongst physicians, but also understanding that that the same may occur with Asian Americans from various cultures, and I think that may not be well recognized. And so understanding that, and I definitely appreciate what you said about curiosity and wanting to know more about someone's culture so that you can better provide care. So that was really helpful for me. Thank you for sharing. I also wanted to say that in the chat, Lynn Gwynn has provided a link to the Asian Pacific Islander Health Forum, offers excellent strategies for recruiting Asians into clinical trials. So she has a link there. So please click on the link. And it looks like it was from 2021, so it should be really recent. We have Dr. Parker in the chat, and he wrote, what's the efficacy of strategies for community outreach for Asian patient participation in clinical trials, such as places of worship or community gatherings that are used by major stakeholders, such as community patient representatives and also PIs. So looking at participation through places of worship, community gatherings. Can anyone speak to that?
I'd like to start off by that. I think that's a great question, Dr. Parker, and I'd like to hear from the others on the panel, maybe about their experiences in the data. I'm not aware of really hard data to compare the effectiveness of the strategies, but this just sounds like a great idea for implementation. Again, some of that hybrid approach, and one that I'll be carrying while we're recruiting for 1614. I think this has been a really eye-opening discussion about how we can do this for clinical trials ongoing and also in the future. But with, and I know that this type of efficacy has been very well established in the Black and African American population. I know that our collaboration health disparities here at MD Anderson have been really very successful in doing that. But I want to hear from others on the panel whether this strategy has been well studied in the Asian American population.
Certainly read studies where there have been, targeted information for example, in the Korean American community via church groups, as to looking at colon cancer screening, and their conclusions were that those who were randomized to getting more information and actually having, I think it was like a talk plus written information, they actually scored higher on the questions about, do you understand colon cancer? And they actually had a higher willingness to undergo colon cancer screening, which is of course very, very important as an action item for the individual who's participating in that sort of a study. The same has been true for other Asian groups. Sorry, it's slipping my mind now, but there are a number of different studies where people have sort of navigated patients, and met them where they are, whether it's community centers or church gatherings or other sites.
Thank you. Okay. How do you implement? Let's talk a little bit about implementing or starting out implementing diverse recruitment. What are some, I know that Dr. Lee mentioned it definitely starts from the top. That's actually one of the reasons why we are in SWOG doing leadership training in diversity, equity, and inclusion, because we do believe that in order to provide, to have a diverse participant pool, it does start with the PIs and leaders, because as Dr. Lee was mentioning, it has to sort of be important to the leaders, that's the reason why we might, be setting goals for different studies that require a certain amount of representativeness, then it happens. And the reason why, if it can be important to leaders, maybe beyond having numbers, or amounts set, and they may recognize, the importance or the benefit of having diverse participants, that may, facilitate diversity in participant pools. So we definitely think that it starts at the top, starts with the PIs and the leaders. How do you get started? Like, Dr. Huang, how did you get into, how did you find the people to get into the community? How were locations chosen, or, how do you even get started?
Yeah, for this question, I'd like to probably focus on the 1614, and that's what we're in the process of doing. It's open across the U.S. at 150 sites, but what I think is really important is to know who's open and what does that location look like geographically, and what's the prevalence expected of hepatitis B to B in those areas. Is it rural and urban? So I know that the infection, and I know the target population in general, and now it's time to go learn more about the sites. And that's what I think is really important in this next phase, since we've just reopened the study, is to go back to see who are the people who are really interested. What cities do they represent? What people are there? What's their racial ethnic background? And can we engage these sites to actually have community stakeholder, like, can they do the next step out there? Kind of similar to what we did with our liver cancer prevention project in Houston. So we are trying to find these sort of site champions. What I would say is really PIs who are invested in our project. Can we build relationships with them? Can we coach them into figuring out how to get to their patient population? So these are individuals that we're having ongoing discussions in California, and in various areas on the East Coast as well, so that we can build those collaborations going forward.
Sorry, can I also interject that it's also very important when we're talking about, intervention studies, that we really talk with pharma and make this a priority for pharma as well. I described the study of the FDA and the percentage of Asian Americans and Asians in kind of global versus, American studies. Pfizer had a study that they recently described, and there were something like just 2% or so of their American participants in clinical trials were Asian American, and something like 22% of all of their trials actually had a percentage of Asian Americans above the 5.9% level that's in the population, right? So pharma is aware of the really woeful inequities that have occurred over time. While that is, again, aggregated data and has its own, limitations, the same holds true with, how we're thinking about, representation of, our Black and African American patients, our Latinx patients. So I think that, that this is something where when we're designing studies for big cooperative groups or institutions or IITs, that we're also talking with pharma, that this is what's important to me as an investigator, and this has got to become important to you. I think the message has been heard, but it's a matter of making certain that we get that all the important players, funders, drug providers, federal research dollars are hearing the same message.
That as you were saying, the funding matches the efforts that are going to be needed in order to engage engage those participants. All right, and we have in the chat another question and comment. Hildy Dillon said, are we asking Asian Americans of mixed heritage, perhaps their mixed cultural influence? For example, a close relative of mine is a US-born child of Chinese, Caucasian, Jewish heritage. His over 100-year-old grandmother of Chinese heritage lives with their family. We can't make assumptions. I believe heterogeneous heritage is growing in the U.S. This young man said he does not know how to fill out ethnicity forms if asked that request. Hildy, are you still on? Do you want to add to that at all?
Yeah, I just think that it's an interesting question for those of us that have worked in hospitals doing clinical research, which I did early in my career, is that you cannot, especially, I come from the New York City metro area, there are so many people of mixed heritage, as they might be in Southern California or other pockets throughout the country. And I think this is growing, that, and there are many people, I think, today that are in their 20s and 30s and 40s that have influence from many different cultures within their family. And sometimes there are, based on what they look like, there's an assumption that they're going to have certain preferences or behave in a certain way. And I think we have to be especially careful of this because, and be asking people, as we do when we ask them what their goals are for therapy, it's what are their preferences? How do they, who is it that they would trust most in making a critical decision, you know, such as making a decision about cancer treatment. And so that's really my question. We're never one size fits all. And I think this is really growing within our country, so.
Yeah, I definitely think there's not a checkbox for where all of your health influences come from in terms of culture and background and belief. I agree. It's definitely, if you have to choose a checkbox, we're missing something. All right. Are there any other questions or any comments from our presenters? So I just want to thank each of you for each of our presenters, Dr. Lee, Dr. Nueno, Dr. Akoba, and Dr. Huang. I really appreciated, Dr. Lee, your discussion of the 4 U's, the unique, unusual, and unnecessary aspects of cancer that are related to Asian Americans. So thank you so much for that. Dr. Nueno, I really appreciate the question about who is Asian American. How do we, putting everyone in a box and definitely showing us that we have to have that curiosity about who an individual is. That's basically patient-centered care. So thank you so much for that. Dr. Akoba, I really appreciate you talking about how minority patients need to be given the same opportunities and offered the same research as their white counterparts. That's really important because one of the major reasons why people don't always participate in research is because they're just not asked. So that's really important. Thank you for sharing that. And Dr. Huang, I really like you talking about vulnerability, trust, and apply. Having the vulnerability going out with the out into the community, but building trust and how important that is, and then what you learn, how to apply it to the research in an early stage, at the front end, not after the protocol has been completed. So I thank each of you. This has been a wonderful, wonderful discussion. Dr. Lee has agreed to provide his slides for his presentation to be shared. So we thank you, everyone. And if there's no other questions, great discussion and talk. And thank you all so much. You have a few minutes back. Take care. Bye-bye.
Thank you.
Thanks, everybody.
Thank you. Bye-bye.